We'll be getting started momentarily. Hi, everyone. I'm Liz Whitehead, Managing Editor at U.S. News and World Report. Today's webinar is focused on reimagining the patient experience for a new era. While hospitals steadily improve the experience of the people they treat, they are also learning to apply these insights to helping patients and families pay for their care. John Talaga, Executive Vice President of Healthcare at Flywire, recently answered questions on how hospitals can improve their bottom lines while still addressing the needs of the people they serve. Let's listen in on the conversation that U.S. News Managing Editor Michael Morella had with him.
Well, welcome, John Talaga. Thanks so much for being with us.
Thanks for having me.
John, can you talk to us about how patient payments and the patient consumer demands when it comes to paying for healthcare have changed over the past several years?
So there's really two key forces over the past 5 years that have had a dramatic impact for healthcare providers, particularly on the financial side of the house. And one of those is the continued rise in patient responsibility. Estimates are projecting that patient out-of-pocket expenses are reaching as high as, $491 billion by 2025. That comes from an article in Sage Growth Partners. And then the average American household now holds more than $5,000 in medical debt. So this creates a huge affordability problem for patients, and it really creates a large downstream impact for providers with respect to collectability. The second factor is the rapid adoption of digital solutions. This is semi for healthcare fueled by the pandemic, but we've seen 77% of patients think that technology for healthcare needs to be closer to what they personally use in other areas of their lives. And 84% believe that healthcare payment system needs to be streamlined and improved. So that's certainly not a surprise when many healthcare providers are hearing some of the biggest complaints that they have is with the billing and payment system.
And can you tell our audience a little bit about Flywire's work in the healthcare space more generally?
Sure. Flywire in general is a fast-growing global payments and enablement company with deep vertical expertise to serve highly complex industries with high liability. So talking like higher education, travel, and then certainly healthcare. And from the healthcare perspective, we've introduced since 2010, we introduced the first consumer digital wallet for patients. And since then, Flywire has really focused more so on the key problem of transforming the patient billing and payment experience. And we do this by applying predictive analytics, automation to improve how health systems engage with patients. We offer more affordable payment options, and then just as importantly, removing the friction for paying medical bills in general. So, and in the healthcare side of our business, we're very mission driven by making, positive impact on patients' lives and ultimately leading for the provider, who are our clients, a yield to increase their collections and reduce cost.
Can you help us understand a little bit more about the technology at the root of all of this? How are you incorporating things like AI and data-driven tools and other innovations in what you do?
Yeah, so healthcare is at very early stages when it comes to kind of harnessing AI. I think most industries are still rapidly growing and trying to figure that out. But what Flywire is doing for health systems is really kind of a tangible example of how you can start and how you can apply things like AI and machine learning to really reshape how we approach an old process of billing and collecting from patients. So let me give you some context on that. Almost, 50% of patients can't afford an unplanned medical bill for more than $400. And the average balance of a hospital visit is about $1,200. So there's a very broad range of what patients can afford, which requires a very personalized experience that hospital EHRs just don't have. So Flywire offers an automated solution for providers that does three things. We analyze data, we engage patients, and we make it easier for them to pay. And to break this down a little bit, we're identifying a patient's capacity to pay at the time of their bill. So that means what was their payment history in terms of how they paid the hospital in the past, aggregate data that we have across clients and demographics, and then credit information such as credit to debt ratio, employment status, income. And we use this information then to engage the patients with a personalized payment offer. So typically a hospital sending a bill with $1,000 balance, and they're really not taking into consideration of what that patient really can afford. So that offer is really what kind of captures the attention to take action. And equally as important, we're learning their preferred communication method driven by their response. So email, text, paper statements, which still exist pretty heavily in healthcare, chat, what time of day are patients responding, the frequency of which it takes to get them to respond. And that really kind of forms what we call a conversation profile for that patient. And then ultimately, that's what's driving the payment. So we always say that the problem in healthcare when it comes to the experience of payment isn't the process of entering your credit card and processing a payment. It's getting the patients to pay. There's a huge inventory of patients that frankly can't afford what they're being billed and will either ignore the bill and end up in bad debt, or require heavy phone calls and negotiations over the phone with their call center staff.
You all just unveiled a new integrated financing platform, which really is also designed to help patients with healthcare affordability, make things a little bit more personalized for them. What does that look like? Can you kind of shed a little additional light on that?
Yeah, so it's really the kind of the next phase of what we call our affordability suite, in terms of adding this. And just to give you some background, the rising cost of care, is continuing to increase, and it's a major problem for patients. Recent survey of 2,000 patients that we did, 85% stated that they're concerned about the rising cost of care, and 40% have actually admitted to putting off a visit or a procedure because they believe they couldn't afford it. So, I mean, it is to us, and it should be alarming to all of us. And the payment plan terms that a hospital are willing to extend just aren't long enough to meet what a patient needs. And, at its core, what financing does is it allows a provider to sell the receivables to a third party, extend longer terms for a patient, and zero the balance off their books and accelerate cash. But we work with leading health systems around the country, and while they recognize the patient benefit or the financial benefits of using third-party financing to solve this problem, they just didn't like the options that are on the market, which essentially send patients outside of their system to get a loan to pay for their care. It's an onerous application process. Not everyone qualifies. They would, often incur interest when they're on that plan, and many models even return funds if a patient defaults. So it really doesn't kind of solve the entire problem, and it really puts pressure on how they want that patient experience to be when paying for their care. So to solve these challenges, we worked with our clients to develop and launch what's called a fully integrated financing solution. So along with our partner Payzen, we allow the provider to extend financing as part of their regular payment and payment plan experience for both the patient and the call center staff. So provider chooses, what plans stay provider funded, traditional payment plans extended, or those that are financed, but it's all transparent to the patient. It's all lives in the same experience. So this also includes the key principles of what they didn't like about the other solutions of having real-time underwriting. So there's no application process. Every patient qualifies. They're extending this to those that need it most. There's no interest ever charged to the patient. And the plan is non-recourse, meaning that the balance stays zero on the books, regardless of whether the patient defaults or not. So we're seeing significant results of this early on, whereas an increase in collections, since the patients have more options to pay, and we're accelerating cash for the providers by no longer holding balances on their books. So it's been really well received early on since our launch.
Great. You've already started to talk about this a little bit, but just to ask the question directly, how and why does this benefit patients? Are there any stories from people that could help us understand kind of the human impacts of programs like this, especially because, you shared some statistics and we've all seen that medical debt has emerged as a major, major challenge for so many.
Yeah, I mean, just kind of, level setting some of this more is that, more stats is less than half of the Americans are setting aside more than $50 per month for medical expenses, right? So, I mean, that's somebody that's really doing a good job and being responsible with it. 41% of Americans are carrying debt due to medical bills. So, as part of this overall affordability suite, which includes integrated financing, the key thing for the patient, we have stories all the time from our clients that we have patients that are engaging and asking for terms that the health system just can't extend to them. So they may limit their terms, as an example, to 24 months. And a patient may be calling where they need a balance to pay of $75 a month which would mean 48 or 60 months payment. The hospital just isn't in a position to be a bank, right? They wait longer for their cash, they risk default. So by them having the ability to give their patient a 60-month term, as an example, to meet their $75 per month that they can afford, and getting that engaged with them is getting more patients to pay. And then it's also doing this in an automated self-service way, is getting less patients to call and have to go through those negotiations. So those have been some really big things that we're seeing. We're also seeing 27% increase in plans. So this is a direct correlation to the patients who need the longer terms. And we're certainly monitoring closely, and the impact that we're expecting to see is ultimately higher volume for the hospitals for those patients that would no longer have to put off care because of affordability.
Well, in terms of the impact on providers as well, what are some of the results you're seeing, or what responses are you hearing from the institutions in that hospital and health system community that Flywire works with?
Yeah, I mean, one example we have is a customer of ours, Penn Highlands. They're a rural health system in Pennsylvania, and just kind of talk about the whole experience as opposed to just the financing experience. They have multiple bills from physician groups, outpatients, and it really creates a lot of billing confusion because they're getting all these bills and intake that they've got to sort through and figure out what they owe, match it up with their EOB. And this is really challenging for patients to understand what it is that they even owe, right? So it all starts with a patient agreeing with the balance they're being billed that they owe this balance. And then it's about giving them affordable options. So what we do is we did for Penn Highlands, is we consolidate all these separate and disparate billing entities into a single experience. So one bill, one balance, and they can set up one payment plan across these multiple, what would be separate, disparate bills. So this has been a huge improvement just on their patients to call on the phone less, understand what they owe, and it's been a cost reduction for them in terms of dealing with things separately. So we're taking a manual process that's time consuming, and we're really automating that for both the staff and the patient. So some of these results that we're seeing at Penn Highlands is in the last 12 months, they saw a yield improvement of $5.8 million. So really big number for a health system like Penn Highlands. And 78% of those patients are paying self-service. Before Flywire, there was still a lot of the manual payments, questions, things like that. So now we've increased the digital payments dramatically to reduce some of that manual work on both sides. So this resulted also in 8,000 staff hours that we've saved in the last 12 months. And I think one of the things that comes up a lot in healthcare is staff shortages, turnover, difficult hiring. So the more automation that we can place, push over to self-service to the patient, increases the patient satisfaction, and then of course reduces the amount of time they need staff to be dealing with phone calls.
Some really impressive results. We've covered a lot of ground already, John. as we move into a broader discussion about improving the overall patient and care experience, from accessing to navigating to paying for care and so on, do you have any final thoughts or takeaways you'd want to share with our audience of health industry leaders?
Yeah, I mean, the patient experience is a broad clinical and financial initiative, right? And I've listened to actually recently some presentations for programs that were very impressive for how they're looking to improve the overall patient experience. And the focus is on transparency, ease of registration, changing mindsets for how staff interact with patients. But, there has been limited focus on the affordability side. Payment plans that are just based on balances, as an example, are not a strategy for affordability. It's just a mechanism for collecting payment. And nor is just sending emails and text. I mean, I think any hospital can send a text or an email out. They should. That's not really a digital strategy either. So these things have to be coordinated. They have to be, driven by data, really to create a truly personalized experience. Certainly Flywire helps do that, but that even should extend beyond just the final leg, which is the payment and billing process. And I don't really believe any patient experience improvement program should, is really complete without that side of that side of the business. So that's would be my takeaway is, look at everything from end to end. And we're certainly seeing more hospitals do that.
Thanks so much for your time today, John, and for sharing those insights.
Thank you. Appreciate you having me.
Once again, thanks again to John Talaga at Flywire. Now I want to broaden the discussion, and I'm very pleased to introduce our panel, who I'll invite to turn back on their cameras and their microphones. So you can find full bios of our speakers today, along with links to past and future webinars at usnews.com/events. We'll also be archiving a recording of today's session on that page. Now, with us today, I'd like to welcome Dr. Albert Chan, Chief Health Information Officer at Sutter Health, Erwin Cho, Chief Consumer Officer at Presbyterian Healthcare Services, and Alicia Warenga, Senior Director of Patient and Family-Centered Care at UMass Memorial Medical Center. Thank you all so much for being with us. And as I said, I'd love to broaden the discussion, expand the conversation about patient, consumer, family experience. Could each of you just briefly share a little bit more about your own roles, your institutions, and how you're working to do just that, improve the experience for those that you serve? Albert, maybe we could start with you.
Thank you, and good afternoon, everyone. So I'm Albert Chan. I'm a practicing family physician at Sutter Health, and as mentioned, Chief Health and Information Officer, where my role is to ensure both improve the experience of care and the experience in delivering care for over 12,000 clinicians and 53,000 employees. And technology is a huge part of a huge tool set for us to do that, but we have to make sure it really flows into the workflow. So that's what I'll share today.
Well, Erwin, how about you?
Hi, everyone. Given it's the holiday season, I'd like to start with gratitude. I'd like to thank John and Flywire for sponsoring this panel on this important discussion. The financial experience is a critical key moment for patients and health plan members. We'd like to thank Michael, Liz, and everyone at US News and World Report for the opportunity to share a panel with two very impressive leaders, Dr. Chan and Alicia Warenga, in delivering great patient experiences. Thank you in advance, Michael, Dr. Chan, and Alicia, for your insights and conversation today. Of course, I want to thank the healthcare and industry leaders who have joined us today for their time and their contributions to healthcare and the communities they serve. I have the privilege to serve as the Chief Consumer Officer for Presbyterian Health Plan. We are part of Presbyterian Healthcare Services, a nonprofit integrated healthcare system with a multi-specialty medical group, hospitals, and a statewide health plan that covers all lines of business. And in my role, my goal is to improve the consumer, digital, and virtual care experiences. And this includes understanding the consumer journey, identifying key moments, and driving cross-functional improvements to ease the way for our health plan members and patients. I partner closely with many operational leaders and their respective teams who are responsible for the operations to make these improvements. And we are fortunate to have the support from our operational leaders and from an innovative leader, the health plan president, Brandon Fire, who created the chief consumer role here a couple years ago. And so I'm sure we'll get into some of the other areas of focus, but I'll leave it there in the interest of time. Thank you, Michael.
Absolutely. Yeah, I'm very excited to get into a lot of that. Alicia, you've said that your role and your title alludes to this, but your role involves capturing the patient and family voice. Could you tell us a little bit about that? Tell us about yourself and your institution.
Yes, of course. Thank you, Michael, for having me. And I look forward to the conversation with Dr. Chan and Dr. Chow. So I am the Senior Director of Patient Family Center Care at UMass Memorial Medical Center in Worcester, Massachusetts, which is in central Massachusetts. We are a 900 licensed bed, and we're about 220 ambulatory clinics. So to your question, Michael, in my role, I focus on patient family centered care and the strategy around that. So I work really closely with digital health, health equity, DEIB, and many of the other departments at the medical center, but truly take great ownership in making sure that we capture every patient and family voice. We do this through surveys, through the Office of Patient Advocacy, through patient and family advisory councils, and many other different avenues. I think why it's so important as healthcare is changing, we really need to listen to the patients and what they're saying. I think we can capture, but what we do with that information, because we need to be open and have listening ears to make sure that what we are creating in healthcare works for those whom we are serving. So thank you.
Thank you as well. So, our session is titled as a look at the patient experience, but I think it might be more appropriate to say that we're also looking at the overall care experience, not to minimize patients, but to recognize that it is also their family members, their doctors, their whole caregiver teams that are part of this process and journey, along with consumers, health plan members, and so on. So let's talk a little bit more about that. I think each of you have kind of alluded to the cross-functional teams that you all work with and the layers of perspective that you're minding with each kind of care experience and overall care journey. How do you approach this concept strategically at your organizations, and how are your own institutions or ones that you're familiar with kind of evolving their views of experience to make care more affordable and personal and culturally competent? Albert, maybe we could start with you, but I'd welcome thoughts from all.
Great. Thank you for the question. It's a really important and topical question. I think our strategy is to really be inclusive, as you sort of suggested, about the end-to-end experience of the patient and the providers and caregivers. So, I think it's really critical to take a critical eye look at that, because if you try to do one thing in the absence of considering the context for the other stakeholders, you often struggle to get the outcomes you desire. And I think it's there's so much noise in the current environment that at the end of the day, what we want to do is care for people and figure out how to do that effectively and efficiently. So what we try to do is really take this sort of 360 view of the world and say, hey, how will any change or any new feature or function impact both the patients, of course, and their families, also the caregivers and the rest of the staff. And in that view, for example, when we launch a project, we say, hey, what are the impacts 30, 60, 90, 120 days out? And we're very rigorous about that, because we believe that any intervention that you do to try and improve the patient should be studied and appreciated.
Lauren or Alicia, other thoughts?
Yeah, I'd be happy to. So when I kind of think of what we are doing for the overall care experience, one of the things that I really focus on is how to integrate the family and the care partner into our healthcare systems. I think when we look at our country, right? We've done this in certain pockets, but have we done it well, right? When we look at other countries and take their examples, they really have integrated the family and the care partner into their healthcare system. So one thing that excites me with all the things that we're doing in healthcare is really challenging each other on how we can truly integrate care partners, families onto the care team as we move our health systems forward. So really, when we think of the overall care experience, one thing that's top of mind for me is really integrating families and care partners into our healthcare systems, which I think we will be able to do.
And if I could add just a couple comments to this, we begin with thinking about what's the problem to solve, and one area of focus, probably familiar to everybody on this call, is access to care. And we here in New Mexico are seeking to improve access to care for our members in a state that has a low percentage of dedicated providers for older residents as well as all of our residents in terms of resources. And so when we think about key measures for progress, we're thinking about improving that consumer satisfaction with access. Is it easy to get the care and tests and treatments, the appointments that they need with specialists and other providers? Did they get the care that they need when they needed it? And did they get their routine care? And as Dr. Chan mentioned, we need to think end to end. So we start with the consumer's journey, thinking from using tools like human-centered design, developing personas, interviews, observations, to identify key moments that matter. Then we take the data to prioritize, measure, and monitor progress with both leading and beacon metrics, in-process metrics, and ultimately those lagging satisfaction metrics. And so just to give you an example for those that are interested in some of the weedier parts, but looking at something like effort metrics and thinking about repeat calls. Did we resolve their issue the first time round or not? And then once you have that consumer journey and you start to understand what service model underpins it, I want to use a familiar Edward Deming's quote about every system is perfectly designed to get the results it gets, rings true here. You have to understand what the system is designed to do, what changes need to be made to the design, and then develop key initiatives to drive those improvements. And those journeys will cut across different channels: physical, phone, text, digital. And we are at the beginning really of in the industry of developing more omni-channel approaches to the consumer journey, meeting them where they are at those key moments. And so it's even more powerful when you're part of an integrated delivery system like Presbyterian. And I have the fortune of working closely with our delivery partners on more compassionate and more connected care and coverage.
That's really helpful. And I wonder if, you all could kind of probe into some other examples that either you're doing or you're looking at your institutions. Obviously new technology is advancing rapidly, and we saw such a rapid scaling up of telehealth during the pandemic, but also things like predictive analytics, data-based approaches, AI, that a lot of that is moving forward with really great momentum. Albert, I wonder if maybe you could talk a little bit about kind of technology and your perspective, and even share a little bit about Sutter's My Health Online and other tools there that might be, again, thinking about this sort of holistic patient, but also care experience.
Sure. Thank you. So I'll reflect on a story that really changed my perspective on this whole issue. So I was seeing a patient, this is in February 2020. I was seeing a patient who, he and his wife came back from Asia. They were on a cruise ship. They came in with cough, fever, and fatigue. As we know now, that was the beginning of COVID. The experience I had was quite a life-changing one. We were preparing for these interventions, so I gowned up. Can you imagine? So I gowned up with all the protective PPE gear. I went in the room, I swabbed them, I did all these things, I talked to them. It was truly a life-changing event, because it made me realize this is not just about technology, it's about being able to, as has been said, is access to care. And so I really, at that time, for example, we had a plan to scale up telehealth. The plan was slated to take 2.5 years. we actually, in response to the pandemic, as many systems did, scaled it up in 4 weeks, 5,000 clinicians in 4 weeks. And we went from about 7,000 video visits a year to about 1.1 million that year. So the change was tremendous, and it's really opened up new avenues. We continue to learn. So obviously the pandemic has abated in some sense, but we've learned new approaches. So for example, our behavioral health clinics, where patients probably feel more comfortable at home discussing their concerns. We continue to see upwards of 70+% of the visits being done virtually there, for example. And it's also really made us look critically at like consumer-based approaches to things. So for example, we knew that during the pandemic, patients were seeking care, but we were overwhelmed with calls about COVID symptoms and so forth. So we deployed AI technology to actually not replace doctors, but have a conversation with patients 24/7 to help them navigate to the care that was appropriate for their case. For example, was this really a COVID? Were these symptoms consistent with COVID or not, for example? And that extends to even today. For example, we live by text messaging. All of us do, right? We do this all day, even if we're next to each other walking in the halls. It's funny. So we at Sutter Health, we said, okay, how can we really transform the experience using a very simple approach like that? So we now have this robust text messaging platform that, for example, can guide a patient's family throughout the stages of surgery. So when the patient comes out of surgery in a thoughtful and efficient manner. Or, for example, enable patients to confirm appointments or get appointment reminders, which cuts down on we're all busy, right? So it cuts down on the inevitable no-shows that might happen, and enables people to do things like check in virtually to save themselves time. But probably more powerfully, what we've done now is that we've actually been able to, through some standardization of processes, say, hey, not only are we doing this in English, we can now do this in Spanish, Chinese, Russian, Vietnamese, all with the power of technology like this. And it has been truly transformative.
Yeah, if I could jump in here, Michael. New Mexico, like 2 years ago, I was in California, probably a stone's throw from Dr. Chan. And moving to New Mexico was a real eye-opener. New Mexico is the 5th largest state by landmass, with a little more than 2 million residents. And I think some counties in the Bay Area probably have 2 million residents. Much of it is very rural, and we have to leverage innovative technology to provide care, particularly to the rural and frontier populations. And our role in CX, or consumer experience, is to make that experience as effective and easy as possible to drive appropriate adoption of technology for care. And so we partner with our medical group partners, our digital partners, and our external partners to deliver that experience. And I want to give an example. Of course, we this year released, of course, meaning many other organizations have a portal, of course, and a mobile app. And we partnered with the Chief Digital Officer and his team here to release a new portal experience and our new Presbyterian mobile app that includes many of the things that Dr. Chan's talking about, including having your membership ID, claims and benefit information, bills, pharmacy, access to their health records, scheduling, and many other features that you'd want in a mobile app or portal. And this is pretty standard for our organization now to continue to invest in these digital properties. But to give you a more care-related tie, we are implementing expanding remote physical exam solutions called TytoCare to increase access to providers and specialists. And these devices have an exam camera, a thermometer, otoscope, a stethoscope, a tongue depressor, oximeter, blood pressure cuff to remotely send data back to the clinician. And with the mobile app and clinician dashboard, we can conduct remote physical exams, review exam data, and communicate with patients in a HIPAA-secure environment. And this solution can be deployed to the patient's home or located at a rural provider clinic to provide increased access, particularly to specialties where you need that critical mass of patients to support it, like cardiology and neurology and rheumatology. And unlike Dr. Chan, I only play a doctor on video, not a doctor by training. So I did want to just to mention some of the things that we're doing here at Presbyterian.
Yeah, Erin, just to kind of jump off of that, so I'm a people person. That's why I have, this job, being for patient family-centered care, and I'm always worried about this balance of technology as it's advancing and making sure that we're connecting with the patients. And just to share an example that actually took me by surprise. So I flew down to Dallas to go to a conference, had my phone where I had my ticket, flew, scanned, then I used Uber, used my phone again, then I had the app on my phone for the hotel, was able to log into my room and had my room key and scanned my room key, and I was in my hotel room in Dallas. It was a wonderful experience. I didn't talk to anybody. And I surprised myself saying, there is a way in healthcare that we can do this if it's done right? So really kind of took myself by surprise, and just excited to hear your examples and where we will move with this. So thank you.
Yeah, Alicia, actually, I wonder if I could pitch this question to you to start, but again, welcome anyone's perspective. Those examples I think are really interesting and instructive, and I wonder if you could talk, and you first, but really any of you, about some of the feedback you're hearing from patients, from users, and how that may have informed changes or maybe informing ways that you're rethinking approaches to whether it's an app or a portal or something different about kind of the experience. Alicia, does anything like that kind of come to mind for you? Or?
Yeah, I think definitely, as kind of I mentioned at the beginning, right, really capturing and listening to the patient voice. So I think one thing over the past 2-3 years that we've had to really kind of dive into is the patient feedback that we receive in social media, on the internet, and making sure that we are aware of it. We are interacting with those patients as they put that feedback on social media. I think we've had to shift. I think of the Office of Patient Advocacy, it's all done by phone call. We do have some digital parts to it, but I think of a 23-year-old picking up a phone and complaining. That's pretty rare now, right? They really don't talk on the phone. So making sure that we are meeting the needs of all of our patients, and we really have had to shift when it comes to the positive and negative feedback that we receive, but making sure that we are paying attention what's being said on social media, health grades, WebMD, Google reviews, and making sure that we're ready to have that conversation on those different platforms. So that's been a change for us, but a good change, and it's really challenged us.
Albert, same question, of course, from kind of the patient or user experience, but I wonder too about clinicians and nurses and caregivers, if that's something. Again, all of you are working with such a broad constituency of partners within your institutions and beyond, but I wonder if there's anything kind of feedback or changes to, say, a workflow for care teams too, that is informed sort of a new approach to something.
Yes, thank you for raising the question. So I think what I like to consider in these sort of questions is really the intended and unintended consequences of any deployment. Really, I think this is a critical issue. We all can, wax poetic about the possibilities of things when we apply new technology, but we should think about, okay, what's actually going to happen, and how do we manage those things? So here's an example. We've seen over the years, and certainly after the pandemic, tremendous adoption of digital solutions and rapid adoption of, for example, of messaging your doctor via these secure patient portals. And we've seen upwards of 2 or 3x in terms of volume. So, and this has resulted in some of our clinicians spending hours after seeing patients face to face or video, doing documentation, responding to emails, so forth. It's a huge opportunity for care, which is wonderful, and it improves access to care almost certainly. But it also results in clinician burnout, because this tremendous amount of work that you're spending, you're spending time away from your families. This is not just about hours of work, and we're all used to working very hard. It's about, gosh, I'm missing the soccer game or the dinner with family, and so that there's a human cost, a human element to all of this. So we've had to be very thoughtful about this and say, hey, how do we provide tools that benefit both the patient and the clinicians? And here's an example of something we're piloting now, is using artificial intelligence to help with this. So in our deployment, just a few weeks now, really is a deployment that says, hey, when a patient's message comes in, let's actually try to use artificial intelligence to, if you will, predict and draft a response to that message to help the physician out. So the idea here is, hey, read the message, read the chart, use the AI to do that, and say, hey, what kind of draft response can I help the clinicians out with? The clinicians, of course, ultimately are the communicators of the message, so they have to review the message and decide whether it's worthy of sending straight away or need some edits or rejection. And so are very early. So I don't want to, I don't want to be Sandra Bullock and promise world peace yet. But let me just say this: it seems to be quite helpful. In our early trials, we see, let's say 7 out of 10 of these messages drafts are helpful in some way. And if you think about why is this important, so if you can shave off a minute or two, if you can be more inclusive about the questions that patients have, and make sure you don't miss anything. What we're doing here is not artificial, it's augmentation. So I actually like to say it's augmented intelligence, which is to say, hey, we're not trying to replace doctors, we're trying to make them better. So in that vein, we can respond to the patients better, faster, and more comprehensively, and do it in a faster way so I can still have dinner with my family. That's fabulous. Similar vein, we're using artificial intelligence, for example, in radiology. So we know our radiologists are very diligent, working so hard to take care of these patients, and often returning reports on images within minutes of seeing the patient, which is pretty impressive. That said, things are missed. And what happens in that vein is, hey, we need to help our busy clinicians with tools. So we're actually using an AI platform today that actually reads the report of the radiologist. It looks at the image of the radiology image, and it says, hey, I think you may have missed a lesion in the image. And we'll send it back to a second radiologist to review. And we've actually detected cancers that would have potentially been missed if we hadn't applied this solution. And by the way, this is not just a project. This happened to my brother-in-law, my cousin-in-law. So it's very real to me, these issues, and these are very important for all of us to figure out. And so these things have real stories, real meaning for our patients and our staff, and so we work very hard to try to come up with these solutions.
I don't know about the rest of the audience, but I'm taking notes as Alicia and Dr. Chan talk, as some great insights here. And Dr. Chan, greatly appreciate you weaving in the personal stories and narratives behind the work that we do. Like Alicia, we use surveys, consumer advisory boards, calls, and many other forms of collecting the voice of the consumer. And the feedback will probably be unsurprising to the audience. Patients and consumer and user feedback are really connected to how effective are we at meeting their need, how easy do we make it, and ideally key moments where it evokes an emotion. And we've had feedback that indicated long wait times for providers and specialties. I'm sure this is no surprise, coming out of post-pandemic with both clinician burnout and at the same time, all the pent-up demand for particularly in-person care. And so this is one of our core initiatives, working on wait times and availability of key specialties and primary care, particularly for our seniors and our most vulnerable population. And to that point, you can't, there's the old phrase about, boiling the ocean. Given that I'm in the desert here in New Mexico, I say sweeping the desert. You can't spend your time trying to sweep the entire desert. And instead, what John mentioned at the beginning in terms of a data-driven approach, figuring out what are the biggest volumes of issues, complaints, friction points, and tackling those first and sort of going down the list is really important, given limited resources and organizational focus to improve those experiences.
I'm so glad you brought that up, Erwin. I know it's a great challenge. So glad is maybe not the right word, but I do wonder. We've heard from so many industry executives in previous webinars and in our reporting that shortages of staff and supplies are a real issue and can lead to those longer wait times or gaps in critical medications or treatments. Do you maybe to Alicia and Albert, do you have any initiatives or examples of things that you all are doing to to kind of minding those shortages, minding burnout, to kind of make an impact and make a difference there for those you serve?
Yeah, I think one of the newer solutions, which has to do with burnout of our caregivers, our employees, that was something I never thought I would get myself into, but so happy I did. So one of the things that we did during COVID and is still part of the work we do every day is we created a patient visitor code of conduct. So what this is really setting, we've found out, and actually in healthcare, we have tolerated certain behaviors, and myself as a nurse, right? If it be a racist or a discriminatory comment, even a punch, we would just tolerate it and we would grin and bear it, right? I think after the pandemic, we just saw that kind of increase, right? So just the need to create a patient visitor code of conduct giving the authority of our caregivers to say, that's not okay for you to treat me like that, to talk to me like that. There are consequences to your behavior. That may be that the visitor or family is removed, and there have been times where we've had to remove the patient. Now, I know you're probably thinking of different scenarios, what if the patient has a UTI, a behavioral health patient, but we do this work in the Office of Patient Advocacy where we have an escalation process, but really giving our frontline caregivers, our providers, the authority of the hospital to say, it's not okay for you to treat me like that. So that's really been something innovative that we have implemented over the past year and a half that did come out of COVID, but really helped with the caregiver burnout that we were experiencing, and really given them tools to empower them.
Albert, anything you want to add there?
Sure. Maybe it's just me, but I'm a little absent-minded sometimes. We got so many things going on in our lives. So one of the concepts we've deployed is if you will, a digital wingman. Or I don't know the proper term for digital wing person, perhaps. Maybe that's the right way to say it. So one of the things we noticed for our patients and for our caregivers both is there's these routinized things, the things we do. A classic example is pregnancy, where you can predict week by week for the 40 weeks of pregnancy what are the things you should have done and when. Now we all know that. So I was compare and contrast. So I looked at, for example, the what to expect when you're expecting book, and I looked at the first edition to I think the 18th edition now. The only thing that's different is the picture. The font's the same, in fact, turns out. But what can we do to change the experience? So we said, let's do a critical look at this and say, okay, how do we create a digital wing person for this experience? So we deployed this solution called Care Companion that essentially says it detects when a patient is pregnant and in our system, and it says, okay, hey, we believe you're pregnant. Are you pregnant? And we just enroll in our program automatically. It actually relieves the care teams from doing this because it actually does this in the background. So it doesn't require the busy physicians and busy care teams to try to enroll the patient. And then it issues week by week guidance. It says, okay, this week you need to get your shots, or this week you need to get your prenatal screenings. And what we saw 8 out of the 9 months, we saw reductions in message volume to our clinicians from these patients who use this tool. What we interpreted that as saying is, look, we anticipate the needs of our patients in advance. We offer this to them in a warm, proactive approach, and that actually answers their questions in advance and saves both our care teams and them the time to send a message. And we're now doing this in many other venues. We're doing this, for example, one big problem in pregnancy and postpartum is postpartum depression and antepartum depression. And obviously the huge cost societally and personally and families with regards to behavioral health and depression. So we're actually using the same platform to now screen people for depression earlier on at multiple time points that are appropriate to say, hey, let's try to catch these patients in advance and try to intervene before something bad happens. And that's been a powerful experience to say, hey, we're looking at this and trying to intervene in a proactive stance. We're also doing this in things like colonoscopy screening. So it turns out, by some measures, colorectal screening, it's colorectal cancer is one of the cancers you can prevent if you can find it early. But by some published research, maybe 1 in 3 patients actually miss the opportunity to get colorectal cancer screening because they missed the prep instructions properly and to properly adhere to those things. So again, how can we do, maybe it's TMI, but how can you prevent this wasted effort to try to get ready for this colonoscopy and miss that opportunity if the prep instructions are not followed to point on point. So and again, this is not just a nice care experience. This is about catching cancer early or catching depression early in postpartum depression. So this digital wing person idea is something we're trying to do in many service lines today, and it's getting lots of traction.
If I could add one comment just to build on Dr. Chan's comment about preventative care. I think we talked about some of the shorter term. What are we doing right now to sort of alleviate the shortages and particularly associated with clinician and other clinical staff burnout. But longer term, and Dr. Chan and Alicia would love your thoughts on this. Longer term, I think we're expecting a trend of more provider shortages, and ultimately improving our community and population health, and thereby reducing the healthcare demand will be critical. And our organization's accelerating its investment in things like value-based care models and population health strategies to improve health outcomes, reduce care needs, and do a lot more of that catching those preventative where we can, having more preventative care to catch cancer before it happens in other areas. So I think ultimately we need a healthier population because it's unsustainable between the supply and demand of healthcare. And we got to figure out how do we help our populations and communities get healthier to alleviate those shortages in the future.
Yeah, Erwin, I agree with you, right? The shortages are not going to go away. I think it's really, and that's why I always go back to that example of flying to Dallas, right? Of just like, there is a way for us to improve access, improve preventative care, kind of with technology and really doing that human connection, because we know that 10 years from now we're still going to have the provider nurse shortage that we're currently experiencing. So how do we build from that? So thank you for that, Erwin.
Yes, Erwin, I'd love to, and Alicia, echo your comments. Look, there's no easy silver bullets to these things. It's obvious to me that we have aging population. We have a provider workforce that's is essentially increasingly asked to do many things. Just think of the old days. I'll take a simple transaction. In the old days, if I ordered a test for a patient and they didn't get it done, oh well, I didn't know. They didn't know. I give them a paper slip for requisition and it went away. Now I get an alert in my in-basket. And I get tons of these each and every day, as an example. Like, how are we gonna, we have to take new approaches to these things. So, for example, we are now also using remote scribes to actually try to address these burnout issues, potentially saving an hour or 2 hours per day per provider, to try to, if you take this from soup to nuts and say, hey, what can we do to make the experience overall better? Let's take each step in the transaction, each step in the journey, and try to incrementally improve it. And I think that's critical.
I
the time is flying by, but I want to see if I can slip in a few more questions. Here's one actually from someone in our audience. The questioner asks, how are you navigating the needs of patients with intellectual and developmental disabilities? Anyone want to expand on that?
Yeah, definitely. I think we're on a journey, right? I think we're learning, but really, I think technology really has helped us in this space. Being able to have a child life provider hop on a remote call and they're present and able to work through a patient visit. But really, I think in the digital space, it has helped us. I don't think it's perfect. I think we have to continue to be open on how we can improve it. But I think adding the right resources to it will only make this richer and will help us to give this patient population better care. So looking forward to where it goes. But I think that's when I go up to the pediatric floor and looking what Child Life is doing. One thing we have now is we have a child robot on the pediatric floor. So this robot kind of goes around to the different patients, and it's a way for a pediatric patient with any cognitive or emotional, they can connect to this robot, and this robot remembers this patient. Really intuitive and interesting, but it's been really interesting how the pediatric patients have connected with a robot, right? Which I at first was like, how is this going to work? It's working. So, yeah.
Well, Erwin, a different question for you. This about kind of transparency. How are you responding to the calls for greater transparency around costs and outcomes and things like that? And is there anything you've implemented or considering? Specifically in the interest of responding to calls for greater data and information sharing?
Yeah, on this one, like many other organizations, we have cost estimators that will help our patients and members better understand their costs. We have a long way to go, and just in the interest of time here, we'll go into all the details, but we're really looking to improve that financial experience that John started the whole conversation with.
Yeah, and Albert, very quickly before I turn to kind of a final thought from each of you, Sutter has a cost estimator. That's something else you've been working on too. Could you talk about that briefly?
Sure. So we wrote a cost estimator tool that looks at your spend experience throughout the year and then tries to give you a estimate of what your next payment will be, how much for example, a procedure will cost you. And again, to my earlier point about the need for rigor in these sorts of deployments, we actually published this work in JAMA Network Open at the journal, where we actually saw that patients who experienced this fee estimator tool, and they said upwards of almost 80% of the patients said, just by essentially being able to plan for the cost of care, knowing about this information in advance, actually improves their overall care experience. Just this one fact alone of these patients. And to address the concerns of physicians who are worried that if we were transparent about costs, we would actually, for example, discourage people from getting care. We saw that essentially less than 2% of patients altered their care plans in any way based on these estimations. And actually, many patients elected to choose us instead of other folks because we were transparent about care. So.
Well, in the minute and a half or so we have left, I do want to just hear from each of you. There's obviously a lot that we missed or that we could have gone in greater detail on. Is there anything, what's particularly meaningful for you, or is there something you want to highlight or kind of reaffirm or share from a resource sharing standpoint? Erwin, maybe we could start with you and then Alicia and Albert.
But I might take it in a slightly different tact.
Sure.
I want to talk about our vision here at Presbyterian. And our vision really is a unique articulation. And it's one of the reasons I joined Presbyterian. And our vision is to receive a letter from a patient or member saying that we help them make their healthcare journey easy and affordable. And what we want to do is strive to earn that letter so that we're delivering on our promise to respect our patients and members while providing that compassionate, safe, high quality care and coverage that we all seek. And that letter says, "Dear Presbyterian," and I'll read it really quickly. "Thank you for knowing me, respecting me, listening to me, and treating me with compassion. You ease the way to my best health and provide me with the highest quality care, the lowest possible price. You communicate clearly and accurately, coordinate my care, and involve me in decisions. I appreciate that you do what you say you will do. Signed, patients and members." And that articulated everything for me. Thanks.
I know we're at time. I'll be quick. So I'm kind of jumping off of Erwin, just making sure as we move into this new era of patient experience that we intentionally listen to our patients, families, and each other. I think it's important for us to share the work that we're all doing and to learn from each other as we move into this space. There's lots that we can learn from one another. We're all doing innovative things. So let's continue sharing the work and learning from each other, because we're gonna make healthcare great. So perfect.
Okay, final word.
I'd just like to close with really a bookend to what Erwin started off our discussion with, which is giving thanks. Thank you to each and every member of the audience who continue to serve healthcare and our patients. We've been through a tremendous time of change, and we've made it through a pandemic, for God's sakes. And I just want to thank each and every one of you for continuing to serve. I mean, this is, for me, this is like why we all did this, right? Why did we go through school and education and training? It's for moments like this where we can actually care for people in the most profound ways ever possible. So thank you. And thank you for your continued commitment to healthcare.
That's a terrific note to end it on. And I want to thank our audience as well. And I want to thank the three of you, Dr. Albert Chan, Alicia Waringa, and Erwin Cho, for your time, for your insights, as well as John Talaga, Flywire, for sharing his thoughts with us earlier in the session. Once again, you can find more information at usnews.com/events, along with a recording to this session. Thanks for being with us. Hope you can join us again.
Thanks. Thanks, everyone.
Thank you.